Hello everyone, in this video we are going to talk about various causes of membrane over the tonsil, or we can say various differentials of membranous tonsillitis. The first cause is membranous tonsillitis. It occurs due to pyogenic organisms. In this, an exudative membrane forms over the medial surface of the tonsils along with features of acute tonsillitis. The second cause is diphtheria. It is slower in onset with less local discomfort, and the membrane in diphtheria it extends beyond the tonsils onto the soft palate and is dirty grey in color. It is adherent and its removal leaves a bleeding surface, and urine may show albumin in these cases, and smear and culture of the throat swab will reveal Corynebacterium diphtheria. The third cause is vincents angina. It is insidious in onset with less fever and less local discomfort. Membrane which usually forms over one tonsil, it can be easily removed, revealing an irregular ulcer on the tonsil. And throat swab will show both the organisms which are typical of the disease, namely the fusiform bacilli and the spirochetes. The fourth cause is infectious mononucleosis. This often affects young adults. In this, both the tonsils they are very much enlarged, congested and covered with a membrane. Local discomfort is marked, and lymph nodes they are enlarged in the posterior triangle of the neck along with splenomegaly, and blood smear shows more than 50% lymphocytes, of which about 10% they are atypical, and white cell count may be normal in the first week but it rises in the second week. And pole Bunnell test, also known as mono test, it will show high titer of heterophile antibodies. The fifth cause is agranulocytosis. It presents with ulcerative necrotic lesions not only on the tonsils but elsewhere in the oropharynx, and the patient is severely ill. In acute fulminant form, the total leukocytic count is decreased to less than 2000 per cubic millimeters or even as low as 50 per cubic millimeter, and polymorph neutrophils they may be reduced to 5% or less. In chronic or recurrent form, total count is reduced to 2000 per cubic millimeters with less marked granulocytopenia. Sixth cause is leukemia. In children, 75% of leukemias they are acute lymphoblastic and 25% they are acute myelogenous or chronic. While in adults, 20% of acute leukemias they are lymphocytic and 80% they are non-lymphocytic. Peripheral blood shows TLC more than 1 lakh per cubic millimeter. It may be normal or less than normal. Anemia is always present and it may be progressive. Blast cells they are seen on examination of the bone marrow. Aphthous ulcers they are the seventh cause. They may involve any part of the oral cavity or oropharynx. Sometimes it is solitary and may involve tonsils and pillars. It may be small or quite large and alarming. It is very painful. The eighth cause is malignancy of the tonsils. Squamous cell carcinoma is the most important and presents as an ulcerated lesion with necrotic base. Lymphomas they may present as unilateral tonsillar enlargement with or without ulceration, and they may simulate indolent peritonsillar abscess. Ninth cause is traumatic ulcer. Any injury to oropharynx heals by formation of a membrane. Trauma to the tonsil area may occur accidentally when hit with a toothbrush, a pencil held in mouth, or fingering in the throat. Membrane appears within 24 hours. The 10th causes candidial infection of the tonsils. Thank you.